Hey, can y'all hear me? Oh, where'd my mic go?
Yep, you're good.
Okay, perfect. Hey, good to see everyone. Thanks for waiting.
Yeah, no problem. Hi.
Awesome. Okay, looks like people are joining in. Okay, let me just set up the recording here. Okay, perfect. Okay, I'm gonna share my screen with y'all. Okay, can y'all see the screen? Okay, excellent. Okay, perfect. Yeah, we had some good questions this week. There was quite a bit, and like I think they were all like really complex too. So I don't know if anyone else noticed that. So that's good, and I think that really shows the level of complexity of stuff that we deal with. Like this stuff isn't simple. Like it's not just like you go look through a textbook and you answer, or you follow an algorithm either. So yeah, I think why don't we just get started? So Manu, are you here?
Yeah, hi, how are you?
Okay, perfect. Okay, so yeah, let's go through your stuff then. So you had mentioned questions regarding weight gain induced by psychiatric medications, especially when options like metformin are not well tolerated. Okay, so what are your preferred farm options for managing psychotropic weight gain when metformin is not tolerated? So when you say metformin is not tolerated, what are you referring to specifically?
Like one case, she basically had started having a lot of like GI symptoms, like diarrhea, a lot of like stomach upset. So she wasn't able to take that.
Gotcha. Yeah, and I think so. That's definitely a good point. The stomach upset of metformin. That's the biggest thing that limits it by far. How long did you try the metformin for?
She took it for like 4 weeks, and it just kept getting worse.
Okay, and at the lowest dose, the 500 milligrams.
Yeah, 500.
Okay, yeah, that can happen with metformin. So if that happens, right, like there's definitely other options. So like you mentioned, the GLP-1 agonists, those are the ones that are always that they're becoming more well known in psychiatry. Truth be told, so when I was doing residency training, we pretty much just like never managed weight gain for antipsychotics. We just said, oh, like it's something that uh, you just dealt with. But I think now things are shifting that, okay, like this is a real problem and we definitely want to manage them. So the GLP-1 agonists, I think they're going to be the new gold standard pretty soon when it comes to psychotropic induced weight gain for a couple of reasons. So one is that they're more focused purely on the weight gain and the metabolic stuff. Two, a lot of them are injectable, so it's easy, like once a week. So that can be really helpful. And then three, the other options, like for example, topiramate, those can have side effects and those can also conflict with other stuff pharmacologically. So like topiramate, Vyvanse, the Contrave, the Qsymia, right, the phentermine and topiramate. So a lot of those are really for the binge eating side, right, and like the behavior of the eating, but they may not address the actual metabolic dysfunction that's going on. And that's something that the GLP-1s are better able to target. Does that make sense?
Yeah.
Yeah. Um, but I do think that things are changing, and like even in my own practice now, I'm inclining more towards starting to use the GLP-1s. And that's not something that was even that common in psychiatry when I was training. So I think things are really shifting in that regard. Has anyone else noticed that?
Yeah, I went to a talk for that NEI speaker, McIntyre.
Yeah.
And he was saying that they do a lot of studies because he's from Canada, and they do a lot of studies. His specialty is bipolar.
Mm-hmm.
So they're going to start using them more often also for like bipolar and mood stabilization.
Yeah.
Because they see the correlation with swelling, diabetes, inflammation, and how it affects depression.
Mm-hmm.
And
Yeah.
mood.
No, I mean, I agree. I think all this stuff is very new, especially the inflammatory stuff, metabolic issues causing or worsening depression, inflammation, all of that. Like functional medicine and all these things are really coming into the limelight now. Yeah, as opposed to like your other options, right? So you said, have you had any success like Contrave or Qsymia? So I've never used any of them, but just pharmacologically speaking, right? So Contrave, right? So that's combining bupropion and naltrexone. So that is also for the behavioral side of things, right? The emotional binge eating, that kind of thing. The downside of combining them, so if you already have an antipsychotic, right, you're assumably treating bipolar or like schizophrenia, but bupropion is very stimulating. So if there's a psychosis, there's a potential risk of worsening that. Plus, there's a potential risk of the dopamine agonism conflicting with the dopamine antagonism of an antipsychotic. I mean, it's more complex than that because they target different regions. It's more of like a theoretical risk, but it's there nonetheless, right? And then with the Qsymia, right? So that has that stimulant component as well because it's phentermine and then topiramate. And so the stimulant can also be worsening. It can help the appetite, but not necessarily the metabolic stuff. And the stimulant can worsen bipolar and psychosis too, which normally would be because it's not a full stimulant, but that effect could worsen it because normally you would be using the antipsychotic to treat those things. Does that make sense?
Yeah.
Yeah, that would be my thoughts on it at least. And then I know Richard had mentioned that most patients tolerate Tirzepatide better than semaglutide. So Tirzepatide is like Mounjaro, Zepbound, whereas the semaglutide is Ozempic, Wegovy, or Rybelsus. So Richard, I was curious. So what way have you found that patients tolerate the Tirzepatide better than semaglutide?
Hello. I have found it to be helpful among my peers. I haven't found any literature supporting this. I actually brought it up to another group where we go over articles, journaling, etc. They were not able to find any. This is completely my own experience. I have 3 other peers that I have gone on GLPs, and at some point they couldn't tolerate the side effects such as vomiting, and they eventually got put on Tirzepatide, and all those symptoms went away, disappeared, something of the past.
Got you. Okay. That is worth noting. So I was doing a little bit of research into this, and so what I found is that, so the Tirzepatide, so basically the semaglutide, that's the Ozempic, the Wegovy, the Rybelsus, that is just purely GLP agonism. So it slows down that gastric emptying, right? So contributing to that sensation of fullness. And so, that helps the patients basically eat less. But then, but that can cause a lot of issues like the nausea, right? So the GIP or the Tirzepatide, it has the GLP-1, but it also stacks it with a little bit of GIP activity. So that's a glucose-dependent insulinotropic polypeptide, and that actually promotes a little bit of gastric emptying. So basically, it helps offset some of the delayed gastric emptying of the GLP-1, and so that's why it's thought to reduce nausea and bloating. Yeah, but I think these medications now, like, they've been around for a little bit, but now they're really coming into the limelight. So there's going to be a lot more discussion and use of their field in in our field, at least, I think in the next 5 to 10 years. Yeah,
Is it hard to get it approved from insurance for the?
yeah, good question. I've done it for one patient, and I had to fill out a prior auth for her. So and I had to say that she had tried a few things before. So there is some resistance, yes.
Gotcha.
Yeah, what's y'all's experience been?
Another experience that I had, actually not myself, the residents training in my facility, tried it for a patient that also had comorbid alcohol use disorder, and the cravings went away by a margin more noticeable than trying naltrexone, which was very interesting.
Interesting. Okay. Okay. Yeah. Sorry, chat. Yeah. So now it sounds like there's evidence for the GLP-1 agonist you're saying for substance use disorder, specifically alcohol.
Correct.
Yeah. Interesting. Yeah. I'm excited to see what comes and develops from it. Yeah. I know you mentioned. So, Manu, you mentioned for question 4, right? Are there any specific patient profiles or comorbidities that help you decide which weight loss agent to initiate? Yeah, it's a good question, right? So let's say I'm going with, for example, Vyvanse is one of the most common ones I've used. So I often do that if there's binge eating and comorbid ADHD. You can use topiramate if you want some of that mood stabilization activity too. So if the patient has a lot of up and down moods, right, then you can use the mood stabilizing component to help along with the binge eating component, right? If there's a depression component, then that's when you can use the Bupropion or the Contrave as well. So I just try to see what comorbidities they have and stack it accordingly. And then you also mentioned you have a patient in particular, so she's on Seroquel, prescribed her metformin, right? The GI symptoms. Yeah, so I think that's where the GLP-1s would definitely be the go-to for that, especially if you can get them approved. If the patient's willing to pay for it, then that would be the way to go for sure, to address the metabolic issues as well. Yeah, anything else on that topic? Okay. So, Richard, so you had mentioned anxiety, psychotropic options for bipolar affective disorder, already stabilized with anti-epileptics, right? So what options you would recommend? So great thinking on the Lyrica and the gabapentin, because, right, they're already stabilized, right? So now you can further get a little bit more mood stabilization benefit from gabapentin or Lyrica. That could actually even let you taper down a little bit on the previous anti-epileptics while stabilizing their anxiety too. So, I mean, that's a great option. Propranolol can be very helpful as well too. Just be mindful that the patient doesn't really bottom out, because I don't know what else they're on. But that, like, especially propranolol XR or a IR BID dosed. Truthfully, you can use an SSRI, because if they are assuming already stabilized with anti-epileptics, right? SSRIs are still used in bipolar patients as long as there's mood stabilization on board. So you could use an SSRI still. You can use Buspar as well too. So, but I definitely like your thought of the Lyric and the gabapentin as well. Yeah, what were your thoughts on that?
Yes, I appreciate it. Propranolol and SSRIs are a great option. So this question was inspired by a particular patient that I go into further detail. I'll read it out for everyone. So this particular patient has bipolar disorder type 2. He's now stable on Seroquel 200 milligrams every night and Deplin 500 milligrams BID twice a day. So measurement-based care shows a decrease from severe depression to mild depression, which is great, but then the anxiety parameter it still gives moderate result. What is interesting to me is that he has leg pacing or restless leg syndrome. I'm not sure how to categorize it, which occurs whenever he sits down. When he's standing up, he looks completely normal. This leg pacing was occurring prior to quetiapine. I immediately thought of EPS syndrome, but it was actually there prior to. The onset was likely when the patient was abusing crystal meth about 10 to 15 years ago. He wasn't too sure, but he's somewhat confident that it started around then. Current urine drug tests do not confirm any other substance. So I was wondering what specific options for anxiety could calm down his restlessness. What are your thoughts?
Yeah, got it. Okay. So if his leg pacing is purely from anxiety, that's when I would think, okay, like an SSRI is a good choice, right? If it's an anxiety related thing. If it's you think a true restless legs type of phenomenon, then I would check the iron levels first and foremost. But restless legs is more of a nighttime thing. It's not during the day. Leg pacing can also be occurring from ADHD too. It's like a hyperactivity thing. And what stands out is that he used the crystal right beforehand, and so that could have been almost a self-medication for ADHD. So in that case, something like a guanfacine or a clonidine could be helpful to kind of calm down a lot of that hyperactivity. I've seen it work wonders, especially for hyperactive kids, and it's used in adults too, like the long-acting forms. So that could be helpful. You can use risperidone or Abilify if it's more of a neurodevelopmental type of stereotyping, but in this case, it doesn't sound like it, right? And he's already on Seroquel. You can also use clonazepam as well, too. I mean, riskier, obviously, because of the previous history, but it sounds like he's clean at the time, right? If he's getting good care, then may not need to judge the patient now based on their past decisions. So all of those can be options as well, too.
Great insight. I appreciate it.
Yeah, of course. Does it bother him?
It's interesting you say that. He has told me it doesn't bother him. However, he has brought it up numerous times. So it leads me to believe that perhaps he doesn't have the insight, but it does bother him.
Okay, got you. Yeah, I mean, if it sounds like if he's sitting down, the ADHD thing is one worth thinking about. I remember I had an attending tell me, okay, if especially in kids, like you see a kid, you just look at their leg, and if they're pacing a lot, like their leg just constantly moving, that's a good indicator that they have ADHD. It's just that hyperactivity kicking in. So, yeah, anything else on that?
I was gonna say I really like clonidine for adults that they
hmm
tried antidepressants and they did not do well. They have really bad insomnia, even like the hypnotics don't work. And clonidine does the trick because it's addressing the underlying ADHD.
Yeah.
They say they don't like feel or see squirrels running in their head anymore.
Oh,
That's what they all
interesting.
say. I don't know.
Okay. Yeah, I like clonidine at nighttime, and then I like guanfacine during the day. Guanfacine is less
Yeah.
sedating.
I use it at night because it multitasks with a lot of things.
Yeah, and I'll get to that there's like a future question too, related to that. So Manu said, which brand of L-methylfolate do you recommend? I mean, I have no allegiance to any brand. I usually just tell them, okay, this is what we need. You can go on Amazon and pick one. Deplin is the pharmaceutical one, but that's the one that you have to prescribe, right? But then the over-the-counter ones, L-methylfolate, just 15 milligrams or 7.5. You can do any. You just have to make sure it's the methylated form. Like there's so many supplements out there, and I think of it like it's like vitamin D, right? Like it's so ubiquitous that I mean it's hard to do it wrong. Anyone have any thoughts or insights on that?
Is there any advantage to prescribing Deplin instead of getting an over-the-counter supplement?
I'm not sure. I've always used the over-the-counter. I know Levita talked about Deplin. It's just that it's more expensive, and then I think insurance may not cover it. I remember we talked about it last week. Yeah, Levita, what were your thoughts on Deplin?
Yeah, the insurance doesn't cover it. It's out-of-pocket pay.
Yeah.
So, I mean, some patients have said it works and they like it, at least the pharmaceutical brand. I do both depending on their costs. So I'll recommend the over-the-counter if that's cheaper for them and they want to try it. But I think it's kind of like, with the stimulants, you have brand and generic, and some patients are more sensitive to the generic and they always need brand. Mm-hmm. So I think it's the same with this. Like, I think some do better with the brand if they could afford it. Quality's better.
Interesting. That's a good insight. Yeah, I would expect that the concentration is more regulated too with the pharmaceutical versus the over-the-counter.
How long would they need to take it to see it working with antidepressant if they're the MTHFR mutation gene?
I would just have them take them continuously with the antidepressant.
Okay. Is there a time that they would feel like it's working, or?
Yeah, usually 4 to 6 weeks. That's what the reps say for Deplin.
Okay.
Yeah, I mean, it's more like a nutritional supplement that's supposed to help the production of neurotransmitters over time, right? So it's not like a magical fix in and of itself.
And you said 15 milligram or 75 milligram?
7.5.
Oh, okay, thanks.
7.5, yeah. If you know they have the mutation, like, you can't go wrong just prescribing it together with it. So that way you can get the patient the fastest benefit possible. Yeah, anything else on that? And then, so Joyce said, which patients are good candidates? Yeah, primarily it's if they have the MTHFR mutation, which you can often find from a genetic test. All right, so Richard said, should an SSRI make psychosis worse, especially when psychosis is not yet managed? And then, you shared a lit review. So basically, what I think about SSRIs worsening psychosis, that happens primarily in patients who are already predisposed to be on the bipolar spectrum. So, because if once they reach it can flip people into the manic side, and then once that happens, that's when they can experience psychosis, paranoia, that type of thing. And so when I look at the lit review, right? So you mentioned that 8.1% of psych admissions were due to antidepressant-related mania or psychosis. So I think the key thing to remember here is that this is a biased sample, right? So these are the patients who are already admitted inpatient. So the vast variety of patients will take it and nothing happens to them. But then the ones that stuff happens to them, they're the ones who get the admissions to them. And it's definitely a thing. I have seen antidepressant-induced mania and psychosis. I've seen stimulant-induced mania as well. So it is a thing, especially in the patients who are predisposed. And then when that happens, it leads me to conceptualize the patient on the more bipolar spectrum, and then look at a mood stabilizer or an antipsychotic in the regimen.
I was going to ask, have you ever heard of a patient that got the mania induction from creatinine and not adequate water intake? Because I had a patient that I suspected that's probably what happened, because that was the only change.
From creatinine? Like the creatinine went up?
No, they were taking creatinine for workouts and not hydrating.
No, so you mean creatine.
And
so
that one.
Creatine
Sorry.
is, yeah. So that's actually a good point, though. So creatine is like the muscle supplement, right? It's a stimulating supplement. Creatinine is the breakdown product from the urine that the kidney
it's because I was ordering labs today.
Oh, gotcha. Yeah. So from creatine, I mean, it's theoretically possible. Creatine is basically creatine increases ATP in the muscles and then also in the brain cells. So that's how it works. It pretty much promotes that increase through, it's one of the biochemical, it's like one of the parts in the Krebs cycle or something. I forget the exact biochemistry. But
because it was the only time she ever had symptoms. And then once she hydrated and stopped that, she went back to her normal baseline.
Do you know what dose she took?
She was overdoing it.
Yeah, so that's actually key. So creatine has a dosage of, the standard dose is 5 grams. However, to begin the creatine, some people will do what's called a loading phase, where basically it overloads it into their muscles and then they go on maintenance. And the loading phase, I forget how much you take, but you take much more than you're supposed to load it, and then you go on the maintenance dose of 5 grams. So that could have been a thing as well. Yeah.
Sounds good.
Yeah, no, it's definitely a thing. Like, I had a patient who started doubling up on their Adderall, and they ended up inpatient as well. And that was the only suspected thought, was like it was because they were doubling up on their Adderall. Like, that was it. Okay, anything else on that? Okay, so Kanita asks, okay, any recommendations on tapering a patient off of Xanax 1 milligram at night and then Restoril 30 milligrams at night? Would like to follow the Ashton manual and transition to Valium. Wondering if I need to split the dose throughout the day, even if he takes it for sleep, right? And then Richard shares the ASM, the addiction medicine guidelines, right? And then gives a titration piece, or a tapering plan right here too, which is very, very detailed. The problem I find is that when it gets too complex, patients just have a very hard time like sticking with it. They forget what to do. Because I remember I had a patient who was on Xanax like 3 times a day in residency, and it was just a nightmare to get her off. And she just, because I was like, okay, we'll decrease like the afternoon dose, and then later in a couple of weeks we'll decrease the evening dose, and she just could not keep track of doing that. So what I started doing was literally just swapping them to the equivalent Valium dose, and then, or Clonopin, and then tapering it off that way. So because it's easier, Valium and Clonopin both have long half-lives, so the withdrawal is less than, say, you trying to come off Xanax. So in this case, right, I think what's nice in this case is she already takes both of these at night. So you could just swap it at nighttime. So you don't really need to do like a daytime thing. And so you have 2 options here. You could either swap both of these for Valium, or you could swap the just the Xanax for Valium. My thought would be, okay, so if the Restoril is already helping her with the sleep, I would focus on the Xanax, swap that to Valium, and then taper off taper off that Valium, and then try to come off the Restoril after that to not affect her sleep as well. That would be my thought. But when I read this question, my thoughts are that, okay, does the patient even want to come off? Because I don't know, like oftentimes patients become very attached to it. And I'm thinking of a specific case where the patient was like, hey doc, I'm 70 years old, I don't care what you say, like I don't want to come off my Restoril. So I'm like, okay, like she was just very attached to it, right? And she was okay with other switches, but not the Restoril. So, what kind of attachment does she have to any of these medications as well? So I think that's worth being aware of. Then you also got to be aware of how frequently are you going to see the patient, right? If you can see the patient every 2 weeks, then you can do it a lot more step by step. But let's say you can only see the patient every month, just due to clinic restrictions or whatever, then that's where the Valium approach really comes in handy, because then you can spread it out over a long time. And it's simple too. That way it's not like you're managing like piece by piece. So it depends on how frequently you can see the patient. So I think that's important to recognize. Any thoughts on that, or any other experiences?
Are you worried about seizure risk when the patient is on 2 separate benzodiazepines?
Good question. Only if there's like a predisposing history of seizures. In this case, the Xanax dose isn't terribly high. Like 1 milligram is not too high. So I wouldn't be really concerned about a seizure risk, especially if we come down at a decent pace. Like, you drop down 1 dosage point a month. Yeah, I wouldn't be too worried about it. Yeah, have you ever run into any kind of seizures, while tapering?
So, that's a good question. last year, my hospital, I'm sorry, there has a benzodiazepine taper off clinic that is referred electronically. They eventually see the patient, provide motivational interview, and so on and so forth. They, at some point, came across a patient that had a history of seizures, which, as you mentioned, it's already going to be a problem as they taper off the benzo. This particular patient was given a mood stabilizer or antiepileptic just to mitigate that risk. I thought it was a very interesting pearl to take along.
Yeah, that makes sense actually. To just block off it sounds like they were just being more cautious. Like they didn't really need to do that, but they were just being cautious with it.
I was going to say we do something simpler where I work when it comes to benzo tapering, because we see a month later because we're so packed. We usually just lower the benzo by like 2 to 3 tabs each visit.
Yeah, gotcha.
That way, if people are struggling, like looking up the taper dosing and that, pretty simple.
Yeah, you got to just work with what you have. And I think that's the important thing. Like all of these are just guidelines in an ideal world. And as we all know, real world psychiatry almost never follows these kind of guidelines. So, nothing beats that clinical experience that you get. So,
Have you ever, I'm sorry, I didn't mean to cut you off. Dr. Dhawan, have you ever seen an actual seizure? I had several patients already that had stopped abruptly despite the education intervention, as high as 1.5 Xanax dose. I was wondering, maybe you've seen it in clinical practice.
So I have a good question. I've never seen it personally. I've never had a personal patient who's abruptly stopped their Xanax. I have seen it with alcohol, but not with any kind of benzo. But it's definitely a thing. There's no doubt about it. It's definitely pharmacologically, biologically a thing to the seizure risk of coming off a benzo too quickly, especially if they've been on it for a while. And the higher the dose of the benzo that they come off, the bigger the change, and then the more risk of seizure.
I agree. When I rotated to consult liaison, I saw a few chronic alcohol use and abrupt discontinuation.
Yeah, no, it's a thing for sure. So definitely have to be very careful of it. And patients that do have to be, if you're taping off a patient, you should definitely tell them, do not discontinue this because of that risk. Yeah. Anything else on this topic?
When you were in residency, was there like a specific guideline you followed when you were tapering benzos?
No. So when I was in residency, we just kind of took it patient by patient. So I remember a couple patients I had, they were always on Xanax and it was always multiple times a day. So example, that one patient I had, she was on Xanax 3 times a day. The old PCP had her, but then they retired, so she came over to us. And so for her, I tried doing basically just taking off 1 in the afternoon, then 1 in the evening, and then 1 in the morning. But she just could not keep up with it. And she was older too, so it became very difficult. So then I found just switching her over to Clonidine really helped. I have another patient in my inpatient practice. She was on Xanax once a day, so I switched her over to Clonidine as well and did that. But basically, it's more about, rather than following an exact guideline, right? It's more about understanding the reasoning behind the guidelines so you can use it to your advantage. So, for example, that patient in residency, I realized that, okay, I couldn't see her that frequently, and that change was way too complex for her. She was a lady in late 60s. So I was like, okay, I need to make this nice and simple for her. And then actually I had another patient who was on Xanax, and we actually did not switch her over to Clonidine. She was on Xanax, I think 1.5, and I just slowly brought it down each visit, and that was fine for her. But then I have had others I've switched over. So it really just depends on patient by patient.
Gotcha. Thank you.
Yeah. Guidelines are a good guideline. That's why they're called that, right? They're guidelines to learn the concept and to learn a good framework for it. But then that's when your own right? You adapt guidelines to specific patients. and then you do the best you can and you learn from each case. Yeah, anything else on that? Okay, so Natalia mentions, what do you recommend for patients that are not bipolar that complain of unstable moods that have tried antidepressants already? So yeah, good question. So Richard says not truly bipolar, personality disorder could be explored. Danielle says lamotrigine. Exactly right. So I have a couple thoughts reading that. So one is that, okay, so if they're not bipolar, they have unstable moods, and what we need to do is we need to explore the diagnostic criteria with them. So what does this mean, unstable moods? Is it related to BPD? Is it related to ADHD? Is it related to PTSD? Is it an anxiety and irritability? Right? So what is the underlying diagnosis here? Is it a rapid cycling bipolar that we're dealing with? So it sounds like we might need some diagnostic clarity. And so that's really important, because then once we have a diagnostic clarity, then that will get us better treatment, right? So she says they already tried antidepressants already. Okay, so then, right, what antidepressants did they try? What dose did they go at? How long did they do it for? Right, did they just give up after the first week because it didn't work immediately? So then, once you have a good diagnosis, that will lead you down to the treatment, right? Because BPD, you might treat with DBT, might use a mood stabilizer, might use Lamictal, as mentioned here. ADHD, maybe a stimulant, or something like a guanfacine would be helpful. PTSD, right? Maybe they need a high-dose SSRI, maybe they need EMDR therapy, like it's a hyperarousal situation. Maybe they need a guanfacine or Clonidine to help with the physiological arousal that they're going through. If it's an anxiety, irritability, right? Maybe it's the SSRI trial again, or maybe like a benzo or propranolol. If it's a neurodivergent thing, or like a neurodevelopmental issue, right? Then maybe it's like an antipsychotic that we need to help deal with their unstable moods. So this is where I would recommend going back to the diagnosis and figuring out, okay, what is actually going on with the patient? Yeah. Any thoughts or questions on that?
Isn't there a personality inventory? The name skips me right now.
You mean like a questionnaire?
Yeah, I think that there's one. I don't remember the name right now, that we can conduct if we're not sure about the differential.
Yeah.
That it might provide a clue. I'm trying to remember. I'm looking through my notes right now, but I think that there's one laying around somewhere.
I've never used one personally. I'm looking it up right now. So it looks like there's one that the APA has. Here, let me share it. So it looks like there's the one that the APA has, personality inventory for DSM-5.
Is that a PID?
I think this must be it, right?
Yeah, I think that's it.
Oh, PID-5, yeah. So I mean, this looks very, very thorough. I've never used it personally. Have you?
I just always refer out to psychology, just because my preceptor always said, like, especially cluster B, it's something really serious. It's not a light diagnosis. It really affects their career and their jobs and their family. So at least that's what I was taught, that it should take a few visits and it has to be a thorough thing.
I agree. Also, I should have about to mention psychology. When it comes to personality disorders, it's not a medication management problem. It's a psychology problem.
Mm-hmm.
Yeah. So I would say just roll out what you can as far as the ADHD, the trauma, mood disorder.
Yeah.
And then if the issue persists, then that probably tells you it's borderline. I don't know. In my case, whenever I come across patients with personality disorder, you really feel it, the energy shift. They're very draining. They complain about everything. So there's a personality disorder.
Yeah, so I have 2 points
Pretty
on that.
obvious.
Yeah, I have 2 points on that. One is that, I just forgot my first. Sometimes you don't have to wait a few times to diagnose them, because the corollary is that getting the patient the right diagnosis will help them with their treatment faster. So sometimes I find providers are too hesitant to diagnose because of this. So you see this in adolescents, but also in people like, oh, they don't want to put a diagnosis on the chart, but then the patient gets diagnosed with bipolar, unspecified or something instead, and they just kind of get thrown around with that. And then, it's until someone's told them that, okay, no, I think it's just BPD, that it validates the patient and it can help them finally get out the treatment that they truly need, right? Rather than just kind of being passed around because people were too conservative to diagnose it. So
well, what we do is we add it in our section in our notes, the diagnosis part. We put roll out, borderline, or whatever. So that way, whoever sees them, they have an idea like, oh, okay, I kind of have an idea what's going on here.
Right.
Just because I don't want to be the one to tell them, hey, you're borderline, because they're so resistant to change. They're so difficult with me already.
Actually,
if they say, hey, I think I'm borderline, blah, 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 I'm like, hey, I'm all for you going to a psychologist, ruling it out.
Yeah, in my experience, I would think that, but I've actually found the opposite. Every patient who I've told has received it well.
Mm-hmm.
I mean, like,
It's all about delivery.
yeah, I mean, maybe it's the, obviously I'm not I'm not like a specialist in that, but I'd say out of the 5 or 10 that I can think of, they've all.
But did you have a relationship with them?
No, like in the first visit, I mean.
The first visit?
Yeah, like after.
I'm surprised because usually, like the first one, they don't like that.
Yeah, I don't know. I've just had good experiences with it. Maybe they're just drawn to me. I don't know.
That's not a good thing to attract borderline people.
I have a parallel that I would like to discuss if you allow me a quick second.
Yeah.
As you know, I work at the VA where there's a high propensity for personality disorders. It often comes along with complex PTSD, even though they're different diagnoses, they share a lot of parallels. In those that I'm confident to have a personality disorder, instead of bringing up the idea of personality disorder, I change literally one word, and I think that I have received better responses, and that is, I only met you 30 minutes ago, maybe an hour. I cannot be truly sure, but it sounds like you tried a lot of medications. It sounds like you have been given a plethora of different diagnoses. So who really has all the answers? We're not sure, but if you allow me, I would like to bring up a new approach, and that is to explore a personality component. That's a key word right there. Maybe the personality component is affecting the way that you feel, the way that you relate to the world, yourself, the future, etc. Bringing in a little bit of Beck's principles in there. And so far, I have had really good outcomes. Patients are a little bit more open to the idea of having borderline PD.
Yeah, that's really good. It's like it's the delivery, right?
Oh, it's like the same like with bipolar. Instead of saying bipolar disorder,
bipolar
mood disorder,
spectrum.
or say, hey, this could help boost your antidepressant or help with your mood.
Bipolar component.
Yeah. Yeah.
They hate the term.
Yeah. Yeah, the way that I've done it is, so if I'm starting to suspect it, then I'll get the patient's buy-in. So I'll pull up an infographic of, like, for example, BPD, right? I'll even show you the exact infographic I use. But basically, like, I'll pull up the infographic and walk them through it and be like, okay, are you experiencing these things? And they're always like, yes, like, wow, that sounds like me, this validates me. So this one, so like, so this is my suspicion, so like, let me know what you think. So distorted self, like, do you go through this, and just walk through them all by one by one, and then usually by the end of it, they're like, wow, like, I feel so validated, I feel seen, like, this captures me. And I found this has helped me get buy-in into, have the patient get buy-in into it, rather than just me saying, okay, you have this problem. Yeah, like, I found this has just really helped, just walking like through it one by one.
Have you ever had them like idealize you and devalue you within the same visit?
It has happened,
like,
yeah.
Very obvious.
Yeah, it has happened. Yeah, usually not
You
in
go
the.
from being like the greatest person to like the worst ever.
The villain.
Yeah, it's happened to me before, unlike on follow-up visits. But then I usually just remember that it's the patient's pathology. Like I remember I had one case where the patient like really, I mean, loved me, and then I had to switch providers, and then like all because I was leaving, and then all of a sudden, like they wanted to keep following up with me, but then literally they changed their mind in, I think it was like 6 hours, and said, oh yeah, they don't want to see me anymore. So yeah, it's just part of it. But yeah, so I found that, and then there's a second point I was gonna say. I can't even
Could
remember.
you share that one on the app? Or
Yeah,
legal rights, copyright?
yeah, yeah. Yeah, it's just borderline personality disorder symptoms. I just searched on Google, but I'll share it. Um,
Okay.
there's a second point I was gonna say. I can't remember what it was. It'll come. Yeah. Anything else on that?
I just wanted to add very briefly, because I know we've been dwelling a lot in borderline. When they start splitting in a positive way, they just met you and they are glamorizing you. I think that is helpful to let the patient know, I am a complex individual with many different sides. I'm really not that great, but that's a topic that we're going to explore in future visits. And it's one of the several 90833s that we can insert. Doing follow-ups until the patient can get connected to psychology.
Mm-hmm.
So one of the topics to cover, in other words.
Yeah. And so that's actually perfect because it leads into Mani's question here. So she said that she had a question about something entering an eval, right? The patient just talks about very specific things that happen, can't answer the questions directly, has to give all the context, right? Like, have you seen this in your practice? Is there a name for this? So this is definitely a thing that happens. Many patients are very worried. They're nervous, so they don't know what to say. So they kind of just spitball everything at you, right? This is what we call, so it could be circumstantial. Think of circumstantial like a circle where they eventually get to from point A to B, but they just go so much around it, and then they eventually get to point B, but they've given you all this extraneous information. Tangential is when they might be trying to go towards point B, but then they get distracted and they just go off in a tangential direction. In the mental status, you can also say not goal directed. You could say preoccupied with extraneous detail. You could say speech is verbose. Like you can use things like that in your mental status to indicate that aspect, right? So I think you captured it, right? Circumstantiality, anxiety, or maybe even a personality feature. So, but I think the key to your question, right? So you mentioned something about. You said where I don't know where you said it, but you said even when I try to gently move the conversation forward. So I remember I had one attending, and like I could never do this, but she would literally, if the patient's rambling, she would just cut him off and then like ask her question. And you would think that, hey, like there's no way the patient's gonna get offended, but I found that patients literally would just stop talking and then go off with whatever she says. So, that's kind of the extremer approach. I'm not like, I can't really do that. Like, that doesn't really fit well with me. But I definitely am become a little bit more authoritative when I need to speed along the interview if they're rambling too much. So I'll be more directive. I remind them that, okay, hey, we should, let's focus on the essentials here because I want to make sure you get the most out of this interview. And I also start switching to more like closed loop questions or like closed-ended questions. So rather than saying, hey, how do you feel? I might even just go to checklist like, okay, do you feel sad? Is your energy low or high? That way I'm more directive and there's less, they can only give me yes or no answers and not just kind of ramble on. Because it's important, right? It's important for the patient to be able to get the most out of their visit with you too. So it sounds like this might be the concern, like to gently move, like you might have to just be more authoritative, and it's definitely a normal thing. Yeah, Levita mentioned I redirect and inform them that I have limited time for the intake and write questions or concerns between visits for me to read at follow-up. So yeah, so this ties into Richard's Yeah, you wait for them to take a breath to interrupt. Yeah. So this ties into Richard's point as well, too, where he said, yeah, you remind them that you have follow-up visits too, to discuss all these concerns.
Yeah, I think what I was also trying to see was like the way she was answering things. Like I was trying to diagnose her, like trying to see what this is like a symptom of, like over explaining or just like very specific to details, like can't give me like one answer. So I was trying to kind of have that, like maybe thinking a little bit more in that perspective too. There's a diagnosis that I'm missing.
I see. Yeah. So two of them, right? So if it's a pressured speech, that can indicate you towards bipolar disorder, right? If it's pressure, meaning that they're talking, and like it just has to come out and you find it difficult to interrupt them, then that can be indicated of bipolar disorder. Versus if they're so disorganized, right, that they can't even keep track of the conversation, they keep going into different directions, that can be indicative of a psychotic process or something like schizophrenia, right, where they're not able to stay on track with the conversation and it's more disorganized. So those can be clues, like those are all mental status and those are all clues to the diagnostic presentation of the patient.
Or they could be ADHD.
That as well too, yes. Yeah. Anything else on that? Also, so I remember my previous point. So it was regarding the personality disorder stuff. So the second thing I was going to say is that as you get better, you realize that so you become the diagnostic instrument. So, what that means is that Lovita was saying that, like if someone has a personality disorder, you just feel it, right? And so you start to get that spidey sense, you countertransference starts kicking in, you start getting those like clues for the patient. So just like, right, if how like girls and boys always say, oh, they gave me the ick. So, that's like a feeling, right? Like a gut feeling. So I'm not saying that the patients give you the ick, but they give you a certain, like a countertransference. You notice that feeling towards the patient. And then as you get more experience, it's like you almost can't even put words to it, but you get that gut instinct and it's like, okay, I feel like this person's a bipolar flavor, or I feel like they're a personality disorder flavor. And then, you delve into it with your diagnostic criteria to really stabilize it or pursue that thought. But you get these gut feelings, these instincts. And so, it's in psychiatry, especially when a lot of our diagnostic criteria is not as rigorous, like the patient has an A1C of 6.0, so they're diabetic. It's softer in that regard. And so that's where the clinical experience really comes in. And I remember an attending said that to me where he said, you are the diagnostic instrument. And like that always like stood out to me. And then as you get better, your sensitivity gets better and your specificity gets better as the clinician.
Yeah, you know what I do for the bipolar, the moderate mania? Severe psychosis is easy. But the way I describe it to students, moderate mania, they give me a headache and it's really difficult for me to redirect them.
Mm-hmm.
That's my intake. But yes, Emotional Intelligence, Daniel Goleman. Very good book. He talks about that.
Yeah. And that's a lot of the soft side of our field that I think is not often talked about. It's because it's hard. You can't really capture that in a book. It's not like hard and fast guidelines. Yeah. Anything else on that? Okay. So the next thing was, so Richard had a question. He said, psychotropic considerations when a patient undergoes a bypass. Can you cover stimulants as well as their formulation variety? Right. So Levita says she uses IR. Yeah. So IR, of course, right. Basically in gastric bypass, the absorption is limited because the gastric tract is limited. Therefore, we have to get the patient to absorb the stimulant as quick as possible. Right. So IR definitely helps with that. But that's where we have all those different stimulant formulations too. So for example, there's ODT ones, and the ODT ones include Avikio, Edzenis, Contempla, And so all these modules are actually in the stimulant ones, so those should be done, and they're in the classroom section as well. But now you have ODT options, right? So that's oral dissolving. So you can use that to avoid the gastric tract. There's liquid options, which have faster absorption. So Equivalent, Dynavel, Adzenis, those are liquid. There's patch, which is Daytrana, right? So there's a Daytrana patch that you can give. It's methylphenidate based. There's a chewable one called Quilichew. So you can give that as well too. And so I just pasted all this in the chat. And then of course IR formulations. So this way you can help get around some of the gastric bypass issues.
So my follow-up question is, should we place patients on IR strictly, or is there any other further consideration?
So no, with some of the ODT and the liquids, right? So those, or the patch, those are all extended release. So like, for example, Adzenis, that's an XR that's developed ODT. The liquid one, there's Quilivant, which is methylphenidate XR. There's Dynavel, which is the amphetamine XR. And so those are all liquid. So then you get the faster absorption there. You have Adzenis as well. The Daytrana patch, so that's an extended release that lasts for like 12 hours. And so they just keep the patch on. So those are options if you need the XR control as well.
Interesting. How about other psychotropics like Effexor, for example, which is often prescribed as XR?
Oh, okay. I see. Yeah. So yeah, you would try to you want to do the IR or get the other formulations. Yeah, of course. You try your best, right? Yeah. So that would be one indication where you would use Effexor IR over the XR. You just dose it.
Interesting.
You dose it 3 times a day. Yeah.
Do we know if a patient, let's say for example, Effexor, they ingest the capsule, does this capsule get absorbed through different parts of the intestine, starting in the stomach, of course? Does it, in other words, pass on to the duodenum and maybe part of it gets absorbed and so on and so forth?
Are you talking about Effexor or just meds in general?
I'm using Effexor as an example, but I'm also asking for meds in general. Specifically ours, of course, since it's what we're prescribed primarily.
That's a good question. My understanding is that most medications are absorbed in the duodenum, especially in the first section of it. That's my understanding for most psychotropics. I can't think of any that would not be. But I'm not 100% sure on that. Yeah, I don't know. So, that raises the question, right? If they have a Roux-en-Y bypass, then do they bypass the most absorption-heavy section?
Mm-hmm.
Right? It's a good question. Yeah. Yeah. Yeah, so I think that's where, like, if there are many medications, they do have an ODT form. Like, a lot of the antidepressants have liquid forms. The antipsychotics, for example, you have the IM forms, you have LAIs. Saffris is ODT. Some of the stimulants are ODT. So you have different options that you can play with too to help to compensate against that.
Cool, thank you. I appreciate the answer. It's definitely, if I come across this in current practice, going to be an exception, but it's always good to know.
Mm-hmm. Yeah, this would be a rare thing, especially in private practice. Well, actually, maybe not. Like, the gastric bypasses, like, I think they're done less nowadays. They were done a lot more back in the day. But, yeah, I'm sure you might run into it. Yeah, anything else on this? Okay. So, Heidi mentions options for agitation, aggression, lack of sleep with autism, taking risperidone 2 milligrams, Ativan, mirtazapine, melatonin, also on seizures. Yeah, so risperidone, so that's a good choice, obviously. So it's FDA approved for irritability with autism, right? So the aggression, agitation. So that's a good choice. So now this is what Levita was referring to earlier, right? So the lack of sleep. So this is where Clonidine can be a really good choice. It's sedating, but it also helps calm down a lot of irritability, calms down the sympathetic nervous system. So you could use a Clonidine during the nighttime. You could use like the immediate release. You could use the XR during the day. If it's not too sedating. If it is sedating, you could try guanfacine. So that can be helpful as well for agitation and aggression. I like those just because they're way better tolerated than the antipsychotics. So my go-to will always be first there to avoid side effects. But of course, risperidone is it's a standard of care choice for agitation and aggression. Ativan, you might need to just be careful with it, especially if it's there's a thing called paradoxical agitation, where like sometimes they take it and they get disinhibited, just like how alcohol can cause aggression by disinhibiting behavior. Ativan can do the same thing too, because it's a benzo, it hits the GABA receptor like alcohol. So it's just something to be wary of, especially with the Ativan as well. And lastly, another thing I would think about, so there's a history of seizures on 3 different seizure meds. So a consideration could be, okay, what if you collaborate with neurology and you change some of the seizure meds to something that, we also use in psych. For example, Depakote, Lamictal, Trileptal, or Tegretol, right? Carbamazepine. So that way you get the seizure benefit, but then also the mood stabilization benefit too. So that can be worth discussing with neurology as well. Yeah, any questions on that? Okay. So Eugene here asks, your experiences treating conversion disorder, functional neurological symptom disorder, therapies, treatment regimen. Yeah, so good question. I've encountered a couple of these patients, primarily in the child and adolescent population. So I'll tell you like a recent one I have in my private practice. So this kid is a 16-year-old, and basically his story is that he was forced to do basically he's an Asian kid. He was forced to do a lot of extracurriculars and stuff when he was younger, and he pretty much one day he said, okay, screw this, and he started developing movements issues, functional neurologic disorder movement issues, where he would not be able to get up for hours. He would not move, his legs wouldn't move. He could still move around here, but his legs wouldn't move. And then slowly he came back from all of his activities, started dropping out of school as well, switching to online school. And so he calls these things, he calls those episodes strikes. But when they strike, he is not able to move at all. And so he's actually gone through various different programs. So I'm going to share them here with you. So he went through an F&D clinic, actually, in Philadelphia. It was a movement-based clinic that he went to. So he did that. And it was sort of helpful for him. But he also did, I think he did another program as well too. I'll find the program, but he's done that, and now so basically I'm seeing him doing weekly therapy with him to address some motivation, anxiety concerns, and we also have him on Wellbutrin too to really help with a lot of the motivation piece that he's dealing with, but. His thing is that, so he admits now that a lot of these episodes are voluntary. He says that sometimes he can control, if he wants to get out of something, he can control when it happens. For example, if he wants to get out of school, he can control when it happens, and it just won't happen. His legs just won't move. And he says he'll sit in the bathroom, he'll sit in the room for hours. Even if he has to go to the bathroom, he's okay. So point being that, it's a difficult thing to treat. It's definitely it's not easy. And so what you want to do is you want to treat the underlying disorder as much as you can, right? I remember I had another case where basically it was a girl who had a lot of those pseudo seizure type of episodes, inpatient. She was admitted, 16 years old. And so she had a lot of anxiety. And there were definitely the pseudo epileptic seizures, she had numerous EEGs done. And so for her, actually just treating her anxiety and starting her on Ativan was what made the difference for the seizure episodes. Oftentimes there's a lot of psychological distress that's going on. Like in her case, there's a lot of family distress that was happening. I remember I had another case who had the FND with a lot of pain related issues. And so him, we started Cymbalta, and that seemed to at least psychologically help him some. This was when I was in residency. So, but it's definitely like there's no clear-cut treatment for FND. It's often treating whatever the underlying thing is and treating any type of comorbid psych issues. And a lot of people do tend to grow out of it. In my experience, it's primarily been the adolescent population. I mean, I know it happens in older adults too, but oftentimes, especially if it's in the adolescents, a lot of them can grow out of it too. Any,
Have you ever seen?
yeah,
I'm sorry.
now, any thoughts on that?
I have a question. Psychogenic seizures in particular, do you ever discontinue or reduce the lamotrigine, which they are often prescribed by neurology?
No, I do not, unless there's like a clear-cut reason for it, right? But let's say the seizures get better, then I would. Uh,
Mm.
yeah. Yeah, it's so tricky. It just depends on the individual case. Like there's no like clear-cut like, yeah, in all cases, DC the lamotrigine. I think I would try to figure out what does the patient think it's doing for them? That would be the more important question I would ask. What does the patient believe the lamotrigine is doing for them?
I see. I looked up on up-to-date psychogenic seizures, and they recommended to DC it eventually for as long as they have a reduction in episodes. They do recommend SSRIs and plenty of psychotherapy. That is a gold standard for this particular disorder. I have a patient currently who has this disorder. She was a victim of political oppression. Poor creature, she had to be fed through bars in a prison in a Caribbean country. That's how harsh her trauma is. And as an adult, she has endured it. She went through a lot of neurology appointments back to back. She didn't like the diagnosis until she was finally referred to me. The episodes have gotten better after initiating an SSRI that the pharmacodynamic test yielded, or at least suggested, was going to be a better metabolizer. I was able to get those episodes down from happening 3 to 4 times a month to currently maybe once. Lamotrigine is still on board. The SSRI, Luvox was the one that I chose, and she's been agreeable to it so far. So far so good on this patient. It is very interesting. Her mom also suffered from the same disorder.
Okay. Yeah. That was another thing I was gonna say, was that when I was doing researching on the patient I have right now, we were saying the therapy approach is to really encourage the functional component. Like, no matter, just like with somatic symptom disorder, like, okay, whatever is happening, whatever impairment they're having, you have to encourage their function despite it, right? So if it's like a chronic pain thing, you still have to encourage their functioning with it. If it's like a movement thing, right, still trying to encourage, okay, still make small steps, you can still make small gains, right? And then you still try to make their functioning going over time. That's the most important thing in the therapy, that like they can live despite having these situations. Yeah, Manu asks why Luvox.
So I ran the GeneSight test on this patient. She was already sold on it from the previous psychologist. The psychiatrist referred to me in particular. So, just for the sake of engagement, I went ahead and ordered it. She was tried on, I believe, Zoloft, which she was a bad metabolizer for. So it was a good way to get the patient engaged, I'd say. So more than being used as a guide is appropriate for the therapeutic alliance.
Right. Got you. No, that makes sense. That makes total sense. And yeah, that's sort of, see, it's like that real world practice, right? That's what ultimately comes down to. let me share my tab here. So yeah, so for example, so this is like the Children's Hospital of Philadelphia, the CHOP. So they have a somatic symptom and related disorder. They have a whole program dedicated towards this. So they might be, yeah, this is what he did. My patient did. He did the amplified musculoskeletal pain syndrome because along with the, like in his strike episodes, he has the pain, along with the movement issues, he has pain issues as well too. So yeah, that's why we did this, or that's what he did, and he found it was helpful. But I'm guessing what they did was pretty much just encourage functioning for him despite the pain. Like I'm sure that's what it was. So
Can you please share the?
yeah, no problem. So maybe like in your area there might be some kind of functional neurologic program that's available too, especially in a yeah. So this is the AMPS program. But there might be a functional neurologic program, and like especially in a big academic center, so you can always refer patients there too.
Mm.
Wait, sorry, I think I missed, what is this program for?
This is for functional neurologic disorder, specifically for like, so for example, so in my patient's case, right? So he went through this program. It's called the Amplified Musculoskeletal Pain Syndrome Program. So that's what he went through. For because he has conversion disorder.
Oh, gotcha, thanks.
Yeah. Yeah, anything else on that? Okay. And so Kanita asks here, postpartum depression versus adjustment disorder. So yeah, good point, or good thought here. So when I think about these two, I think about, okay, if I say adjustment disorder, right, that indicates mainly a psychosocial type of etiology. So like the mom is feeling distressed from responsibilities of being a mom, right? But when I think about postpartum depression, that's one, more severe, and two, that makes me think of like a hormonal etiology specific to the pregnancy. So that's where like the criteria can really come into it. If you think about it, like I think that postpartum it's more on the hierarchy than adjustment disorder is. So if I'm trying to decide between the two, then and it's a postpartum female, right? I'm gonna go with the postpartum depression, especially if she's having that criteria, because then that tells me, okay, there's a hormonal basis, which there most certainly is if the mom is experiencing that. And so I think that just calling it an adjustment disorder doesn't do it the full justice. Yeah, what are y'all's thoughts?
I agree. It's more intense and severe.
Yes, I agree. Yeah, it's something that definitely, there's definitely a hormonal basis to it, and definitely that's something that needs to be taken seriously. Because it's,
And I've seen also more SI and plans.
Mm-hmm. Yeah, so remember there's postpartum blues, which is kind of like an adjustment disorder. Like I would put postpartum blues and adjustment disorder in the same like hierarchy, and then but postpartum depression is definitely more of a severe thing than that. Yeah, because then there's SI, right? Psychosis can happen, so you definitely need to be wary of that. Yeah, anything else on these?
I wanted to share a resource that I thought was very helpful, and there's a podcast called Psychiatry and Psychotherapy, the computer. I believe it's episode 25.
Do you see this?
Oh, no way.
Yeah.
Do you have a store?
No, I subscribed. I think I like bought a t-shirt or something from them, and so they sent me a mug.
Oh, that's so nice.
Yeah. But anyway, continue.
Yes. So you're familiar with how useful and high yield his podcasts are. I believe, a legend here in my area. He, on episode 25, he actually brings along a psychiatrist who she herself suffered from postpartum depression. And I think it wasn't 25, that it must have been another one. I
Oh, okay,
apologize.
no worries.
There's so he brings along a psychiatrist who she herself suffered from postpartum depression, and it was helpful because not only did they go over the standards of care recommendations, but she discussed her personal experience with it, and I think it's very valuable because it's the experience of a clinician.
Right. This
I'm
one.
trying to find it too.
Is it this one? Sharing it on the screen now.
I believe it is.
Yeah, it looks
Yep,
like.
that's one. That's it.
Yeah. Yeah, and I think that's where the uniqueness of psychiatry comes in. Like our own experiences definitely matter, right? Especially more than other medical fields. And so our experiences help us connect with the patient as well, too. So, like, for her, having gone through postpartum depression, she's going to be a much better candidate to treat those patients than I will be, just from that individual experience. Just like this kid I was telling you about, this 16-year-old kid, like he's a gamer sitting at home kind of deal. So his mom sought me out because of the podcast I've done on gaming disorder. So like there's definite it's such an important piece, to find those patients that you really connect with. And if you speak your truth out, especially on social media or podcasts or writing, whatever it is, then those patients will find you and they'll feel more connected to you as a result.
Agreed.
Yeah. Yeah, thanks for sharing. Yeah. Anything else? Anything else y'all wanted to cover we didn't go over?
I was gonna ask something different. I think last week I had a coworker and she was asking me what the difference is between the Bupropion SR and the XO as far as for addressing ADHD. I've always just used the XO.
Yeah, I've in the 90% of the time I've used the XL. The only time I've used the SR is in the prison population because we don't allow the XL there. That's literally the only time. The only time I can see using it is if the patient doesn't tolerate the XL because it's all kind of given at once. So if you split it into the SR, let's say you do one morning dose, one mid-afternoon dose-ish, then that can help with some of the irritability or the spikes. Or if you want to get some like mid-afternoon coverage, then you could theoretically use it for that. But 95% of the time, XL is what you would use.
Have you also had patients that are taking phentermine and they have ADHD?
No, I've never had a patient actually take it.
I've had some, and I told her we would have to get you off your phentermine and do a stimulant, and she didn't want to. So I'm like, okay, non-stimulant it is.
Oh, really? Yeah. I had a patient on.
They also screen positive on drug screens. It comes out as cocaine metabolite.
Oh, interesting. Okay, yeah. I had a patient on poor guy. So he was on kratom, and he was hooked on kratom, and every like month we were just trying to taper him down just a little bit. Like that was our goal.
And they have those in all those like pop-up shops everywhere.
They're all
the CBD oils and gummies.
He was getting it at the gas station, yeah. Yeah.
People will do anything and they don't even know the ingredients.
Yeah.
It's all over my area. There are so many patients hooked up on kratom. There's a smoke shop on every corner, and I am not quite fond of it. I hate it.
I had a patient request me to prescribe kratom, and I looked it up. I'm like, no, I'm not going to give you that. She was already like paranoid and psychotic. Like, stay away from that. But she still did it. I'm like, whatever.
Right.
Let's increase your antipsychotic.
Outside of the shops, they literally have signs saying, doctor prescribed, insert substance here. It's crazy.
False advertising.
For 100%. Kratom, they'll say it?
I seen, I'm trying to think of this particular store. It says doctor prescribed, and underneath they have a sign with a few of the substances that they give out, like THC gummies, cannabis, and kratom was on the list. So it will make you believe that it's kratom's being prescribed by a doctor, but I have not walked into any of those shops, but I'm pretty sure there's no physician in the building.
Yeah. I remember one mistake that I remember making in residency that the patient actually caught was, so they were on kratom, and I was like, oh well, why don't we use naltrexone to help with that, to help with some of the addiction, but the patient actually caught it, and because he was, I think he was a biochem student, but he said that yeah, so kratom is a opioid receptor agonist, and so naltrexone is an antagonist, so that would compete with that. And he was right. So, ever since then, I remembered, okay, like that's not a strategy to use for kratom addiction.
He wasn't psychotic.
He was not. No, no, he was very well. He was doing like he was one of those types that's like intellectually was able to understand everything, but just wasn't able to
apply it in real life.
Yeah,
and stay away from that stuff.
Exactly. Like we would have the best conversations, like high level talks, but in real life, he just wasn't able to do it.
What's it?
Was he using other stuff or just the kratom? Sorry.
Yeah, he was using alcohol as well. Thankfully he was able to come off the alcohol. He did a New Year's resolution and he did come off the alcohol, but the kratom was it was a sticking point for him.
So I wanted to ask, what is your prescription of choice to get the patient off kratom? Is that Suboxone?
That's the only case I've ever done it with. Like my substance use treatment experience is not very strong. It was just never like an interest of mine. So I've never used Suboxone or anything. But I mean, theoretically, that would make sense, right? To get the opioid blocking, but then also, but I don't know.
That's what I've seen here. I saw Suboxone. I should get more engaged with this population. Every time I see it, my bias comes out, and I'm not thinking about that kind of practice.
Your bias regarding Suboxone or like addiction practice?
No, sorry. Let me rephrase. That I'm biased against addiction. Is in my experience, has been a lot of personality disorders, a lot of motivational interviewing. That it really requires a village to get this kind of population engaged in substance use treatment. The whole team needs to be involved. They need to be asked to come in to do UDS all the time, and it's challenging.
Mm-hmm. Yeah, absolutely. I remember I did a rotation at the VA. It was a substance use rotation, and basically those were the patients I remember had the most difficulty talking. It was an inpatient, so they were there for I think weeks or something, but I had the most difficulty talking with them. Basically, we just had to meet them once a week, and some of the patients wouldn't show up, and they were literally down the hall, and they wouldn't show up to their appointments, and I had to go seek them out, and they'd be smoking cigarettes because like they allowed that in the substance use facility, and it was very, very frustrating. I remember, so I definitely relate to that.
They have a lot of substance use in the VA, though.
They do have a lot. I have some wild stories that maybe I can share in that meeting that we're gonna have in Sunday.
Yeah, I think
we
can end
Sunday.
the recording. Yeah.
Oh, you did? Oh, I'm
yes,
sorry.
You missed it.
Well, let me cut the recording now. I don't think.
Nobody needs to hear this part. Yeah, I know. I forget that you posted on your TikTok and Instagram lives, and I'm like, oops, I forgot. That was unedited.
We're gonna cut out all the recordings. Hold on, I'm trying to.
Sorry, I apologize.
No, that's I mean, that's part of clinical practice, right? It's a very real thing.
What was the worst case you saw at the VA?
Well, it wasn't the worst.